Okay, we're going to move into angiotensin II receptor blockers, which are our ARBs. These are very similar in action to our ACE inhibitors, but they don't have that persnickety cough, so people usually tolerate these much better. We've got one medication here. Again, we're going, if you look at indications, vasodilating, excellent antihypertensives, and sometimes we'll use them for heart failure, which will come up later. Drug allergy, pregnancy, lactation are our contraindications. And then some of our adverse effects are chest pain, fatigue. Hypoglycemia is a new one that we didn't see with our ACE inhibitors. So with our hypoglycemia, we would want to make sure, especially with our diabetic patients, that we're monitoring their blood sugar very carefully. Less likely with the hyperkalemia and cough to occur, so some of our individuals that didn't tolerate the ACE inhibitors will be put on our ARBs. Let's see, let's scroll down here to my drug of choice. I've got losartan, which is my one drug. We use it here for hypertension. I can also use it for heart failure. Contraindicated on this one with our patients with renal or hepatic dysfunction. So again, think if they don't have good renal functioning system or liver hepatic system, then they won't be good candidates for this. Moving to our calcium channel blockers, I'm going to pull over on my calcium channel blockers. We're going to pick this up in chapter 23 because it goes there better, but we're listing it here because it is sometimes used to treat hypertension, usually not as a first line of defense, but maybe if they've tried other things and they don't work, or in synergistically with another medication. Same thing with diuretics. We're going to pick that up in chapter 28, which will come into our next drugs that affect the renal system. We do use those sometimes with our antihypertensive, and they do just what it says. So a diuretic gets rid of that excess fluid, which is going to impact that cardiac output we saw at the very beginning of this chapter. And by doing that, it will decrease that overall blood pressure. We will go over two of our, which brings me to my vasodilators, and they're exactly what they say they are. So on vasodilators, they're going to relax that vascular system. When we relax that vascular system, it causes it to dilate, which is going to lower that blood pressure. For this one, we use them. Usually, they're not the only thing that a patient with a hypertension will get. They'll be used in addition to another medication. So we can use them alone or in combination, but I've typically seen them used with other medications. They are contraindicated with our allergy. They can cause that hypotension. They can cause some cerebral edema, head injury, because of how they dilate vessels. We don't want to use it on an individual that's had any sort of head trauma. So any cerebral edema or head injury, that would be contraindicated with those individuals. And it specifically mentions acute MI, so someone who comes in the throes of a myocardial infarction. They're usually not a good candidate for this one. We do have a couple of undesirable side effects here, the biggest one being that the dizziness, the headache, some tachycardia, edema, dyspnea, some of the things that we've seen before on some of our other ones there. I did want to mention on our toxicity or overdose for these medications that they can produce that hypotension and tachycardia and some skin flushing, which makes sense if you think about dilating those vessels. And our treatment, there isn't a definitive treatment, so it's just supportive and symptomatic with that individual. We have two medications here. My first one is hydralazine. On this one, we can give it, it's very effective intravenously. So if I have a patient that's in the ICU or ER and can't tolerate oral, then or in a hypertensive crisis, we can give that IV. Does a great job with that. I do want to note that the drug combination for this one, when I have it when I have the hydralazine with an anti-anginal medication, is called Bideal, and it's specifically used as an adjunct treatment for heart failure in our Black patients. So that's a common NCLEX question. When we use it in combination with other medications, it does improve patient survival. And then our second one is sodium nitroprusside. We use this one in the ICU when I have a severe hypertensive emergency and I have to use, it's provided IV, so we titrate it based on the patient's blood pressure. So the more I increase the drip rate, the lower their blood pressure, hopefully, will go with this medication. We're going to scroll down to, there's a few drugs that are listed here that don't really fit nicely into one of our previous classes. So just be aware that there are some other ones out there. I won't ask any specific ones on this one. When we're doing our assessment at the very end of the chapter, think anytime you're giving something for hypertension, you have to do a head-to-toe assessment and focus on what goes along with hypertension. So if they've got hypertension, you're also going to see obviously elevated blood pressure. You might see flushing. You might see distended neck veins. You might see headache. You might see eye pressure. So keep those in mind with those individuals. It also talks a little bit about if you're suspecting an MI, what needs to be done with that one. Monitor those patients. That would go down with implementation. Monitor those patients very carefully for hypotensive response to their antihypertensive medication. So be sure we're teaching them on how to prevent orthostatic hypotension, so to change their position. Be sure if we're talking to them about the doxazosin, that we tell them about that matrix they're gonna poop out, so not to be afraid of that one. Make sure we are informing them that if they need to monitor their potassium level at the same time, if they've got that dry cough and it still persists, then they can notify their healthcare provider, and we can maybe switch it from an ACE inhibitor to an ARB. And then their evaluation. So if I'm evaluating a drug for hypertension, I want to see that blood pressure go down. So hopefully we're going to see a decrease in their blood pressure, which is going to make it easier for their heart to pump effectively and get that blood out to their systemic circulation.